Slit lamp examination of the eye. Welcome to the wisdom ride through the eye. Thanks to Dr. Albert Goldstein, who first introduced the concept of slit lamp in the year 1911. To start with the parts of the slit lamp, it consists of the mechanical system, the illumination system, and the observation system. The mechanical system basically consists of a motorized table power switch, table height adjustment control, a joystick to maneuver the illumination and the microscope system together, and the patient positioning frame. It consists of the forehead band, fixation target, canthus alignment marker, chin rest, and chin rest adjustment knob. Moving on to the illumination system, it consists of a light source with condenser lens system, scale for slit height control knob, filter control, reflecting prism, slit width control knob, centering screw, and a latch to tilt the light column. Proceeding to the observation system, it essentially consists of the eyepiece with binocular compound microscopes, prism housing, knob to change the magnification, and the objective lens. Before starting to use the slit lamp, adjust the focus of the eyepiece to 0, mark, adjust the interpupillary distance, and lock the slit lamp, and check that the slit lamp is parallel on the runner's table. Make sure that the observer and the patient are seated comfortably. Once the patient is seated comfortably, adjust the chin rest knob until the patient's eye is in level with canthus alignment marker on headrest. Before proceeding to the slit lamp examination, it is best to be aware of the different illumination techniques. Types of illumination are direct and indirect illumination. Direct illumination is further divided into direct focal, specular reflection, and tangential illumination. Direct focal can be either a broad beam or parallel pipe, and narrow beam or optical section. Indirect illumination consists of indirect proximal, retroillumination, and sclerotic scattered oscillatory illumination. To begin with any examination, start with diffuse illumination with magnification at 10x, wide beam, and longest vertical slit. A diffuser can be flipped over the light source if available, and then start examining from the lids, lid margin, conjunctiva, sclera, cornea, anterior chamber, iris, and the lens. Few pathologies that can be seen are lid swelling, pouching of the meibomian gland, conjunctival cyst, nasal pterygium, conjunctival nevus, band-shaped keratopathy, microspherophakia, iris cyst, and hypermature Morganian cataract. Moving on to direct or focal illumination, a broad beam of low magnification is chosen first to search for an abnormality like corneal scar, limbal dermoid, fibrinous membrane over the intraocular lens, while a narrow beam or optical section is used to investigate in detail on the precise depth of an abnormality. Optic section of the cornea shows the outermost turf film or epithelium, middle stroma, and the deepest Descemet's membrane and endothelium. Here is an optical section of striate keratitis which shows a clear Descemet's membrane detachment. And in corneal scar, the optical section is used to assess its depth. An optical section in acute hydrops clearly shows a Descemet's membrane rupture. The optical section on the lens is used to find the time as well as the grade of cataract. Clear lens, nuclear sclerosis grade 2, nuclear sclerosis grade 3, grade 4 or brown cataract, posterior subcapsular cataract. Principle of optic section is also used in Van Herrick's grading for assessment of the depth of anterior chamber, and narrow slit is focused at limbus to compare the width of the cornea to the dark section between the cornea and the iris when the anterior chamber depth is less than 1/4 of the corneal width. It is named shallow. Moving on to conical illumination. Here, a 2 mm conical beam of light with 16x magnification is focused on to the front of cornea and just in front of the lens to look for cells and flare in case of inflammation. Indirect illumination, in simple terms, is looking outside the area which is directly illuminated. Few pathologies that can be appreciated are granular deposits on the cornea in granular dystrophy, limbal vessels, keratic precipitates at the back of the cornea. Another method of indirect viewing is retroillumination. It is used to look for the patency of peripheral iridotomy, posterior polar cataract, posterior capsular opacification, keratic precipitates, retroillumination of the cornea showing a foreign body. Moving on to the specular reflection, magnification and moderate broad beam is used to examine the anterior surface like the precorneal tear film, and with higher magnification, endothelial guttae can be appreciated. Proceeding to sclerotic scatter, in which a narrow vertical slit is directed in line with the nasal limbus. Moving on to fundus examination, the microscope and the illumination system are positioned coaxially with 10x magnification and 90 diopter lens to visualize the optic disc and retina. Here is a picture showing intravitreal foreign body in the posterior vitreous. Tangential illumination is used to examine the iris while the microscope is aligned directly in front of the eye. Moving on to the various filters, in blue filter shows a dendritic ulcer, corneal and conjunctival epithelial defect, whereas a green filter can be used to appreciate the Fleischer's ring in keratoconus and retinal nerve fiber layer defects in glaucoma.